we listened to three great cytopathologists, starting from Sayyid Ali, who was a graduate of Pindi Medical College and now at Director John Hopkins and this Bethesda. He is the main editor of that thyroid Bethesda publication. Followed by Professor Momin, graduate of Dow Medical University and working at another great institute, Cornell in New York, And third one, Zubair Baloch from Liaquat University of Medical Sciences, Hyderabad. And, another great cytopathologist of international fame, working at UPenn, University of Pennsylvania. So this may be a coincidence that all these three tall figures were born in Pakistan, but that they were also able to achieve such a feat and, status in academics is not a coincidence. It's because of the reason that they somehow landed to a soil which was fertile, right? So, as the saying goes that the talent is universal, opportunities are not. So, to be able to perform optimally and to go to a limit, and sky may be the limit, both seed and soil are important. So they were, very lucky in that sense that talent was there, and then they ended up to a soil which was very fertile. And we have seen that, their work is being followed by the billions on the planet, not millions but billions, and all the patients, all the, healthcare workers are utilizing their work day in and day out, saving lives. So I had this long introduction because I don't have a very long, I want to spend 45 minutes, which were very generously allocated to me, right? But first, again, I will like to remember, our mentor, Professor Shima Hassan, who passed away in the second wave of COVID. And she was one of those pathologists, very rare breed, who, left a strong mark on many of us, She was a very different person, very private person, very quiet person, but a very methodical, pathologist, a true pathologist who will prioritize depth over breadth. She had an inquiry mind, and even till her last days, she used to become so excited, by as you are, as you will expect from a child. And this, what I am going to, present here, it was, I think, I did this before because this paper was published quite some time ago in Cytopathology, and Professor Shima was one of the main person who conceived this and put us to this practice to date. We use a lot of this, this clot thing to increase the sensitivity of our effusions and fluids and to clinch a diagnosis out of nowhere in many cases. So with that, let me move. So this is I'm sure many of you who have been Karachi, uh, this is another, the reddish, I mean, the uh, Shaukat Khana is also looks quite similar. Uh, and this is another new building which came up in the last 1 year, though it was in the making for quite some time. And this is Faculty of Arts and Sciences. So this is a huge state-of-the-art facility, because what happened that a long time ago, the government of Sindh, they uh, you know allotted about 1,000 acres to Aga Khan University for the whole education city, Faculty of Arts and Sciences, just outside the outskirts of Karachi. But as happens, in Pakistan and particularly in the Sindh province, it was just a lip service, and those facilities, I mean, piece of land mean nothing, I mean, if there were so many encroachments, no water, no electricity, nothing, uh, and the original plan was that Faculty of Arts and Sciences will be functional in 2008. It never happened, and so they abandoned it. So instead of their initial vision to remain not going very vertical, they changed their mind, and now many buildings are coming up. After that, another building came, which is the institute, the wing of women and child health. Another great facility. So this is just another beautiful campus if you happen to visit. All right. So the quality of cytological diagnosis depends equally on the excellence of clinical procedure used to secure the sample and on lab procedures used to process the sample. Unlike the biopsies where the entire world is standardized, that a biopsy should be fixed in 10% buffered formalin for that much time, cut, stained in that way, and so on. However, in cytology, particularly when it comes to the cell block, there are multiple ways, and most of the ways are home brewed. The hospital and the department themselves, they evolved whatever suits them depending on their volume and expertise and experience and so on, right? So this varies from hospital to hospital, one geographic area to other geographic area. So use of every bit of this sample, say in all cytology, but here I am concentrating on the effusions, is of utmost importance to increase the diagnostic accuracy and sensitivity. So every bit will be very important. It is, however, am I moved? So cell block preparation is an integral part of cytology, so-called cytohistology. And that's very important for us in this country. I mean, we all are journal pathologists, trained as, our major component is surgical pathology, though all of you and all of us, had to pass cytology examination as well. But this is not like Asif Loya sitting here, or Dr. Qasim and some others, who spent another years, doing a fellowship in cytopathology and then continuously, so that kind of arrangement is not yet here. Though, again, by the primarily by the efforts of the Dr. Asif, the first ever second fellowship in pathology, in histopathology, I think is already, probably next week we'll be closing everything, and then the accreditation process will start, and from 1st January next year, there will be the first intake of the accredited FCPS fellowship in cytopathology for 2 years. We know that in Shaukat Khanam, this fellowship is already in place, but so far it's not accredited. And then I think along with them, Khan University and some other institutions will. So we all are, because we are general pathologists, we somehow, because of our weakness, I suppose, are heavily dependent on the cell block. Because we are more comfortable with histology, because cytology is much more demanding, because there is no architecture. So this is a invaluable, opportunity that we have a cell block, right? All right. So cell blocks very important, as I said, to complement our diagnosis, but also for the ancillary testing, including immunohistochemistry and molecular studies. So cell block refers to the collection of sediment or tiny intact pieces of tissues. Sometimes you have, a very minute biopsies, it's not uncommon to have those very tiny pieces which our gastroenterologists take out from the antrum or duodenum, right? Not uncommon, which are processed as standard tissue biopsies after fixation in formalin and embedded in paraffin. It is, however, a common observation that bloody or hemorrhagic fluids provide better cellular yield than non-hemorrhagic. And it's a traditional, even from the medical college days, we knew that a effusion which is hemorrhagic is more likely to be malignant, right? So that provides a kind of opportunity as well. So this is largely due to the presence of clotting factors in blood, which during the process of clotting strongly bind cells and keep them intact. So, somehow the clots which are formed in these effusions, provide a invaluable opportunity to increase the yield of the cell blocks. So objective, this was a study, a good number of cases, study of good number of cases, to evaluate the diagnostic value of clot examination for satisfactory processing and confirmatory diagnosis in serous effusions in routine cytological evaluations, and all these cases were either ascitic fluid or pleural fluid, right? There may be very few pericardial fluids. So 600 cases of serous effusions were evaluated. So here, first day, the fluid is received, the smears were prepared from each case and stained by somehow, as I said, because we are primarily trained as histopathologists, still we do HNE, besides those those bona fide cytopathologists, they don't like HNE, even they will get angry on you, that why the hell you are using HNE on the, but we still use it here, right? And by HNE, PEP and diff quick or some alternative stain. Cell block were prepared from the first day, conventional cell block, first day sediment by centrifugation at 1000 RPM for 5 to 10 minutes, right? So routine. Overnight sample, and this is, we do our cytotech, senior cytotech, one of the senior most cytotech, Siddiqa Maniar is here. So we do it routinely, every day, that this happens. Overnight samples are stored at 2 to 8 degree in refrigerator, right? sorry, what happened? On second day, usually you will find a well-developed clot is present at the bottom, which is then placed on a lens paper, right? Here, okay, in embedding cassette and routinely processed for 16 hours and now 12 hours or even the fast, depending how urgent is that. So all three types of preparations were screened by cytotex and finalized by the cytopathologist. We are very fortunate that we have some very experienced cytotex, and they screen everything and nothing comes directly to us, and they screen it and then bring all the cases to us. They make a lot of marks on that, on the areas which they would like us to preferentially examine. So they hugely facilitate, So necessary immunohistochemical studies were done on some of the cases for further characterization. So this is the standard what we get, right? The slides, PEP, HNE. HNE is not always mandatory, but most of the time we do it. And GIMSA, right? Or DIFQUIC. And this is the regular cell block, first day, right? And this is the second day clot, because most of these fluids are very hemorrhagic, grossly hemorrhagic. But even if they are not grossly hemorrhagic, they always have blood, So, and I think Dr. Zubair Baloch was going through the, what, we can do to make a good clot and a good cell block. And he mentioned, the plasma and thrombin. In effusions, in a natural way, we never felt the need to add that. Otherwise, to expedite, some of the labs, they use plasma which contain thrombin, and actually what they use is the plasma which is left out or expired in blood banks, not used for the patients. They use that plasma which contains thrombin, and thrombin, that it splits the fibrinogen into fibrin, so it expedites the clot formation. You can do that in FNAs and in some other where there is not much blood to expedite the process. But here, if you keep it, it will in a natural way. The flip side of that is that in this era of molecular diagnostic, you are adding a DNA of some other source, which will then, if it comes to next generation NGS or so on, that's, won't be advisable. That will, lead to some erroneous results. But here in a pure natural way, organic way, we have this clot formation. So this is the cell block preparation on day 1 from sediment. I think this was a pleural fluid, right? And I think Ashish made a very important point today, that in blood-only samples, our trainees write, RBCs and neutrophils and this and that, and sometimes the clinician get the impression that we are talking about some acute inflammation. Those are the native formed elements of the blood, The blood contains neutrophils. So if there are too many, then obviously you will call it acute pyogenic inflammation or lymphocytosis. Otherwise, they are the normal formed elements of the blood. So you should call blood only, as was mentioned by him. So this is the cell block on day 1 from sediment, and calretenin was done, and it picked those mesothelial cells, those most likely reactive mesothelial cells, right? However, from the same sample, this is the cell block preparation on second day from clot. And you see that here, you see, obviously this is all blood, this is blood clot. Blood has a tendency, I mean, they contain the, all these coagulation factors. You see, you got a clump, which is very atypical and looks like a kind of adenocarcinoma, right? This is the higher magnification. There was nothing. The original sediment cell block was negative. Here you have this clump, which is, was not present originally, neither on the smears nor on the cell block. And because the patient was female, one of the immunostain which we included was GATA3. And it so nicely picked that tumor, right? And another one there, you see? It's a very nice nuclear marker for breast carcinomas. So these are the results of those 600 cases that on first day making smears and cell block preparation, 91.3% negative and 8.7% were positive. However, by adding the day 2 clot and again processing as as a tiny biopsy, the yield increased from 8.7% to 15.7%, almost doubled, right? So first day test 1, routine smear and cell block examination, the positivity out of 600 samples was in 8.7%, which increased to about 16% when cell blocks were also used. So increase in sensitivity of detection by adding test 2, that is clot, in malignant serous effusions, predictive value by using pair test and so on, it was highly significant, obviously, as you can see. So in conclusion, cancer cells or malignancy was picked in 7.4% more cases where no malignant cells were seen in both routine smears and cell blocks in serous effusions. And this has a strong implications in, for instance, in our practice, because if we can make a conclusive diagnosis, then they don't need to do any other diagnostic, just maybe clinical correlation and radiology, and they can go ahead with the definitive treatment. Most of these patients are poor patients, and these effusions, if, and great majority of the cases, we are able to make a firm diagnosis that this is a metastatic carcinoma coming from ovary. We can, even with the help of the cell block, are able in a good percentage of cases to tell if this is a high grade serous carcinoma of the ovary or low grade serous carcinoma of the ovary or endometrioid carcinoma or coming from the pancreas or upper GI or rarely the lobular carcinoma of the breast or, but great majority obviously turns out to be gynecological malignancies. So it is therefore recommended that clot preparation should be looked at regularly. In negative, in particular, obviously, I mean, if you are already made a diagnosis on smears and cell block, you don't need that. But clinical suspicious serous effusions. So the message was simple and clear that clot greatly helps. Thank you.